Welcome everyone. My name is Allison Stover Fiscalini. I'm the director of the Athena Breast Health Network, as well as the Wisdom Study, and want to welcome everyone and thank you for joining us for a webinar today on health equity, disparities, and opportunities for research. And this is a conversation with our Wisdom Study leaders. So in today's session, just so you know, your microphones are muted. The meeting is being recorded and will be posted on our YouTube channel after the call. Please send your questions using the Q&A function at the bottom of your Zoom screen. We'd love to have your questions come in and we'll send those off to the panelists. We do have audience polls that we will be asking everyone to respond to. They will appear on your screen and you can simply check your answer. We can take a look to see how everyone is responding. And then after the webinar, we will email you a short post-meeting survey for you to give us your feedback. If there are any additional questions that you'd like to ask, that is a good place to do it. So again, thank you so much for joining us and joining this conversation today. So what will be discussed today is just an overview of breast cancer screening, what it is, how we diagnose it, what are some of the underlying health disparities, and then going into the history of diversity and inclusion, exclusion in research and care, health equity versus equality versus justice, what this means and how do we get there. And then the community perspective, what matters most to the community and community members, what the Wisdom Study is researching, and how the Wisdom Study will impact science, all women, and the benefits of participating. So I'd first like to introduce Dr. Laura Esserman, who is the director of the Carol Frank Buck Breast Cancer Center. She's the founder of the University of California-wide Athena Breast Health Network, as well as the I-SPY trials and the Wisdom Study. And some fun facts: she is also a singer, a songwriter, a theater performer, a mentor, a family person, my boss, and also a professor. And then we'd also like to introduce you to Dr. Kim Rhodes. She's the Associate Director of Community Engagement at the UCSF Helen Diller Family Comprehensive Cancer Center. She has a background, a wide variety in her background, including clinical care, health policy, basic science, health services research, community organizing. She was the third Black woman in history to complete her surgical residency training at UCSF and the first to deliver a baby during residency. And fun facts, Dr. Esserman was actually her mentor during surgical residency. And other fun facts, she plays drums and has 2 teenage daughters. All right, and so next up we have Dolores Moorhead, who is a lead client navigator and multicultural client support clinician at the Women's Cancer Resource Center in Berkeley. She has over 30 years of progressive experience in cancer services, including the American Cancer Society, where she was there for over 13 years. She's also co-authored an article on cancer patient navigators for the underserved. She's won awards such as the Spirit of Activism Award by the Breast Cancer Action, as well as the Lane Adams Quality of Life Award from the American Cancer Society. And fun facts, she previously belly danced with local African American troops, and she is an adult coloring book enthusiast, a jewelry maker, and she loves sci-fi. So we are so happy to have this panelist together to talk to you today about this important topic around health equity, as well as what we can do in research to try and improve health equity in the research and care that we deliver. With that, we will go ahead and get started. We'll start with a poll question. So the poll question is it clear to you when to start getting mammograms and how often to go in for screening? So the poll should pop up on your screen.
Da 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 da. For all you Jeopardy enthusiasts. Okay. What's our answer? Good. I'm glad so many people know. They could tell the rest of the world.
All right. So Laura, I think we'll have you give a little bit of background about breast cancer screening and some of the rates and see if this rate that we just showed seems accurate. So next slide.
Okay. So, the way we screen, currently the way we've screened for breast cancer is for every woman to get a mammogram in the United States. Probably the most common thing is for people to get a mammogram every year starting at 40. However, the U.S. Preventive Task Force guidelines suggest that it should be every woman starting at age 50 every other year. And for people at high risk, maybe to start earlier. Of course, there's no guidelines about what determines high risk. In some countries, like the UK, they screen every 3 years starting at 50. Some start every year starting at 45. There's many different versions of what people do all over the world and all throughout this country. So in fact, it turns out there's really a great controversy. And in fact, in the same institutions, people can get one recommendation from the radiologist and another from their primary care physicians or family physicians, and they are frequently not the same. So this is a problem, and it's caused a lot of confusion. And sometimes in the confusion, some people just don't bother to get screened. And so we feel like if breast cancer is, the most common cancer in women, second highest cause of death in cancer other than lung cancer. And so given that, we feel that it's really pretty critical to do better. And one of the things that we are really committed to is making sure that the work that we do reflects the whole population, particularly at this time when there is now a lot of attention to health equity, to fairness in society, and to the implicit bias in so much of what we do. It is really important to be really clear about what our goals are and why it's so important to be so inclusive. We know that African American women, for example, have a higher risk of dying of breast cancer, and we believe it's because they have a higher risk of getting a particular type of cancer. They're a little bit more predisposed to getting triple negative breast cancer. And this problem has not really been fully addressed, and I don't feel like we've made anywhere near enough progress. And one of the reasons why I think it's so important to be inclusive in research is what informs policy. Clinical trials informs how we give care. Once upon a time, hardly any women were included in research. In heart disease, it was mostly men, and it turned out that those things were not correct for women. Obviously, I'm an advocate for women's health, and I'm an advocate for women. But I also feel like it's time that we really work much harder on these issues of health disparity. And these are problems that have not been solved. And all of us must step forward and make sure that we address them. And in order to address them, we have to make sure that we are inclusive of women of color and all sectors and all walks of life in our research. So we, in fact, have written a grant to make sure that we do a better job and have the resources and time to make sure that women, that women of color are part of our study, that Black women in particular. We need to work harder to develop better tools for assessing risk. We actually have some tools for Asian women, for Hispanic women, that allow us to use some of the genetics and modify our predictions of risk for them. There's been some work for that in African American women, but not enough. And it's not good enough. We still have more work to do. And one of my colleagues, Dr. Fumi Alapade, who is in Chicago, is leading a big effort to try and develop tools that are more specific to African-American women and African women. I've been working with her for over a decade and a half on some of these issues and trying to understand what are the biologic differences and how do we, and there's something we can learn for all of us. What are the ways in which we can change treatment? But again, if we don't get a diverse representation of people in our trials, we have no chance to really solve the problems in the ways that we should. So we are really very committed to solving this problem. And for everyone, it's, starting now changes this, not just for you, but it changes it for generations to come. And I think this is a commitment that all of us can make, to diversity, to health equity, is to start by making sure that the work we do applies to everyone by explicitly looking for differences in populations where we can do a better job of tailoring treatments to the women we serve. The whole purpose of the wisdom study is to really think about, well, what is the best way to screen? Currently, the way we screen is one size fits all. We do it either by starting people at 40 or 50, and we say maybe it's high risk, but what is high risk? We don't know. And so one of the things that we want to do is try and figure out, well, how do we pull in all of the data about risk for each woman and see, does that do a better job than kind of the one size fits all approach? And many of us on this this group, are really committed to trying to advance the field of personalized medicine. But rather than just say a more personalized approach is better, we really need to test it. That's really a very important way of getting people to change, because people are, it's like an old shoe. They're used to doing the same old thing, but that same old thing may not be the best for each person. And importantly, it may not be the best for women of color. It may not be the best for someone who is Latina. It may not be, even the best thing for women who are Asian. So it's important for us to take all this information into account. And that's one of the things that a large study like the Wisdom Study can do. And what we want to do is get the word out on the street that this is a study about women for women. And it needs to be about women of color, it needs to be about women who are Asian, it needs to be about women who are Latina. And if we can get 100,000 people and we get full representation of what our population looks like, we for sure can do a better job of making sure that our recommendations and the ways in which we offer services are going to be better, and do a better job of making sure that people don't die of consequential cancers and they don't get overtreated for cancers that won't kill them.
Thank you, Laura.
Oh, wait, and I wanted to just say one other thing. Kim, I was the first person in my residency to have a baby way back. Oh, I'd say about 20 years before you.
Great. Well, thank you, Laura, for introducing, breast screening and the Wisdom Study and our commitment to health equity. I'd love to have Dr. Kim Rhodes now talk a little bit more and give some background on, what that actually means. And so we'll start off with an audience poll question or statement. So this statement is, disparities are the results of individual behaviors and lifestyle choices. Yes and no. So we'll bring up the poll question now.
Da 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 da. Okay.
Great.
Oh, good.
That's a good start, Kim.
That's a good start.
Your job is easy.
So first, I just want to acknowledge Laura. I continued your legacy at a different institution. So I'm glad to see that people are aware that disparities are really a population level problem, and I'll circle back to that in a second. But I think there's a next slide that just kind of has some prompts on there, and I think what we're going to talk about is, you know, by starting off with what is health equality, I just like to point out that I think that equality, although there's been so much more said about it and so much more sort of battling to get it, it is a distraction. And why do I say that? So if you look at the panel on the right-hand side with this pretty popular picture, but if you look at the three panels, the one to the farthest to the left is equality. And what you see is that there are three kids trying to watch a sports activity, but there's a fence blocking their way. Each of them have the same box, so they actually have equality. Unfortunately, the results of the distribution of equal boxes means that the little guy still can't see over the fence and can't observe the game. Now, if equality were really the goal, what we would surmise here is that, well, we gave everybody the same stuff, and so there must just be something wrong with the person who still can't see. And in reality, what we're really after, especially now in our understanding of what is driving health disparities, is that people need to get, what people should get is what they need. Not that everybody gets the same thing, but rather that people get what they need. And you can even think of sort of, you know, common parlance, like people or kids with special needs. There are additional things we're going to do to help those kids reach their potential. And the same thing is true in health. Equality doesn't get you necessarily to your maximum potential. So in our obsession with precision medicine, you know, this makes sense to us, right? If you have a particular mutation or a molecular marker that can be exploited for treatment, you should get the specific treatment that matches that particular mutation. That's about health equity. So why even focus on health equity? The reason I focus on it rather than equality, besides what I just told you, is that it's actionable, and it reflects back on healthcare systems, because, you know, the kid in the white shirt and the yellow shorts might say, well, probably I should just get the same box as everybody else. But if you're looking from the outside and you are the distributor of the boxes, and you know that your goal is to maximize the potential to see the game, then the distribution of the boxes by an external force would actually recommend that the little guy get 2 boxes instead of 1. And in fact, I think a really important point that is exemplified by the equity panel is that the taller kid doesn't actually need a box at all. And you can sort of think of that as overtreatment in the equality frame, where the person who doesn't need a box still gets a box nonetheless. And we see that in some cases with breast cancer, where folks, depending on where they're being treated, may get more than they actually need. And I think that that is a point that wisdom is trying to get at, as well as making sure that people get the things that they do need. And I just want to say that there really is a dialectic there. The two things are informing each other. The tall guy getting a box when he doesn't need a box just really additionally reinforces the disadvantage of the shorter kid who actually needs 2 boxes, because that second box came from the kid who didn't need it. So there's a balance there that we have to strike. So in terms of justice in healthcare, I think of justice and equity as largely the same. The idea that care is equitable, that it matches what is required for the condition that is being treated, is about health justice. There may be an additional layer to that that reflects on how people are treated inside the healthcare system, because you could get what you need, but still be treated differently based on the color of your skin or any other number of demographic reasons that people might make judgments, sexual and gender minorities, in other categories of folks, immigrants, etc. In terms of you know, where we are on this spectrum. As I said, you know, we've been talking about and fighting for equality much longer than we have recognized that equity is really the issue. And part of that is also reflected in what we know about the history of past abuses of participants in research. And I think folks are pretty familiar with the Tuskegee experiment and the theft of biological materials from Henrietta Lacks that were then not directly monetized, but eventually monetized by turning her cells into a reagent to test just about every cancer drug that's been tested on, you know, in vitro, sort of in the lab on cells. But I think the things that people are less aware of, and I sort of say that, you know, Tuskegee and Henrietta Lacks are our cell phone camera moments from the past. The things that folks have missed are experimentation on slaves and the belief that Black women in particular did not feel pain. So procedures that were performed without anesthesia for the purposes of either teaching folks how to do these operations or just purely for the purposes of experimentation. And that, you know, you can imagine comes from a metaphor of thinking of Black people particularly as less than human, because we would typically do these kinds of experiments on animals. And even at this point, we have to provide and do that in a humane way. So that comes from a long history in our country, obviously, the long shadow of slavery, where slaves were not considered to be fully human. And then the other piece of this, I think that underlying is the implications of the healthcare system in codifying these beliefs by publishing papers about the different kinds of diseases that Black people would get. For example, drapetomania, which was the tendency to break things that slaves had, or rascality, the desire to escape from slavery. I mean, obviously these are not real diagnoses, but if there was a DSM manual, DSM-0, they would have been in there. And then in the peer-reviewed literature after emancipation, there was a belief that Black people would go extinct because they were dependent on the institution of slavery to survive. So you can imagine that this kind of underpinning is going to give you and allow for and facilitate untrustworthy behavior. And we like to talk about inside of healthcare, we talk about mistrust of the system, and that this community lacks trust. And that seems to be trapped in the same kind of less than equal, I will say less than human sort of perspective that suggests that you should have trust even if you've been treated repeatedly with untrustworthy behavior. So I sort of like to flip this idea. It's not a deficit. There is not trust that is missing. In fact, this is instead an appropriate response to a long history of untrustworthy behaviors by institutions. And so the last thing I want to say is just to really emphasize that idea that this is institutions. And I'm not saying that individual providers do not practice in discriminatory, racist, or unjust ways. But what I am saying is that the behavior is rubber stamped and codified within institutions. So when investigators come to me and they want to work in the community and they're, you know, concerned about the lack of trust, I just try to inform them that, you know, that the untrustworthy behavior came from the institution and it came before you. And it will still potentially be there after you leave. So what I want to try to remove is the idea that individuals can fix what institutions have put in place over centuries of time. And so that kind of brings me to this idea of disparities being driven by system level problems rather than by individual level choices and behaviors. And we have for a long time sort of treated disparities, particularly in cancer, as if they were the fault of, well, Black women are obese, don't eat well, don't exercise, don't, deficit, deficit, deficit. When in reality, the only thing that I would have in common being, you know, Black woman growing up in California in common with a Black woman growing up in Alabama is the color of our skin and the way that we both are treated. So why should my outcome look like a woman in Alabama? The commonality is not something necessarily that is in both of our genes, but is more likely to be a system level problem or a system level inequity that treats us both the same or confines us to similar kinds of choices. So disparities is a population level problem. That means it requires system level solutions. And those system level solutions come through health equity.
Wonderful. Kim, that was great. Thank you so much. And we've had a couple of questions come in. One I'll ask right away because it has to do with this picture, and then I'll save the rest for the panel discussion. But someone was asking about the definition of affirmative action in the equity description, because it seems to differ from the definition that they have heard in the past. So just wanted to clarify that.
Affirmative action was an attempt to correct. Am I still muted? Okay. Affirmative action was an attempt to correct the inequitable social and economic treatment and policies that have been sort of placed around people of color, immigrants, sexual and gender minorities, others. But the problem is that it was created in the frame of equality rather than in the frame of equity. And so it is attempting to make a correction without paying attention to the larger societal forces that will still go on even after you have some, I guess, what people might think of as an affirmative action hire or a tokenized hire. Then folks are still surrounded. So that doesn't get you to equity, and it certainly doesn't get you to justice, but it tries to get to equality. And I think that sort of makes the point of why equality is actually probably not what we should be striving for.
Thank you. Thank you. Okay. So we're going to ask another poll question next. So this question is, does your doctor have discussions with you about breast screening and health?
Do we put up the poll? Yeah. Da 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 dee, da 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 da. Okay.
Yeah, this one might be a little, I think the first option got combined with the last one here, but I think you can see what the results are. So looks like the majority of people do have discussions, whether they bring it up or not, which is great. And then the next poll question, the next poll question, somewhat similar. So do you discuss your family's cancer history with your family and loved ones? Yes or no?
Can we get the...
Here we go.
Oops, let me just turn off my... Here.
Okay, let's see. Results are still coming in. So it looks like about 84% of people do discuss their family's cancer history with their family and loved ones, which is great. Great to see that. So this segues into our discussion with Dolores Moorhead. As I mentioned in her intro, she is a client services representative at the Women's Cancer Resource Center, and really is the one who's on the front lines engaging with women in the community and providing information and resources. So really wanted to hear from Dolores, what the community voice, what matters most to the community, where are some of the places where women have noted that they may be not comfortable talking about breast health or participating in research. So these are just a few of the questions that have come in, but Dolores, I welcome you to sort of take the discussion where you'd like to go.
Okay, well, thank you, Allison. And I really appreciate being on this panel with both Dr. Laura and Dr. Kim. when I thought about what matters to the community, I felt like it was important to check with the community to make sure that what I was saying was actually still important. And based on some of the responses that I got, I appreciate that Dr. Laura mentioned that one size doesn't fit all, because the community, individuals have said they really want it to be noted that one size doesn't fit all. Also, the community, the African American community, varies. It depends on who you're speaking to. So, what I may say could be different than what other individuals in the community are feeling. But several of the things that have come up is people weren't told about what was important when you're thinking about breast health, if you should have an annual mammogram. Someone found out by looking at a pamphlet. Another person was saying, especially around breast cancer, that they felt rushed, that they didn't feel like they were part of the team. They were rushed to make a decision. They weren't really given resources, such as knowing that they could speak to an advocate or a patient navigator, or even that they had the right to have a second opinion. Some of the other things that matter are that physicians care enough to look at the individual and get to know that person as their patient and what's important to them and what their story is, and not to lump them in together. The other thing was brought up is the fact that given this health system right now, there's not that much time. You go in, you meet with the doctor, it's quick, and you may not get a chance to have your own questions answered. When individuals are also on Medi-Cal, for instance, they have a fear that they're not going to be treated the same because of the type of health insurance they have. And I really think that ties back into what we've been talking about equity. And another thing is that one person said that they would like to feel like the doctor cares enough about them to know their culture, and if they don't, to not make assumptions, to actually take the time to ask a question, and also to think about if they're going to be talking to this individual and telling them information that could say that they have breast cancer or some other breast health issue, that they make sure that they know to offer resources. Another person mentioned that she never was told when she was diagnosed about the possibility of freezing her eggs. And yet, when she was in a support group that had different individuals in it, they were talking about this. So this is again about equity. If you're giving a message, it should be the same consistent message that the physician thinks about, no matter what that person looks like, and providing that individual that they're working with the option and the choice to decide where to move forward. And with these questions, if we think about health equity, it has many, many layers to it. It's not just one thing. We're talking about people are impacted by education, about food, about their job, the barriers to care. But one of the things that I thought about, when you talk about having health equity, I think it's a conversation that can happen in our community where you can speak to your family, you can speak to your community around the discussion of what does health equity mean? Has someone even thought about it? And also becoming involved, because I believe that we can't sit back and wait for someone else to come in. We have to be the people the person we're looking for. So that means to me, sitting down and saying, what has been your experience? And I think it's really important to include your elders in this discussion, because I believe that elders have a story. They have been there. They are now here seeing some things happen and making sure that they're included in the conversation. Some resources that I would share, just because I've my experience that many times when I'm working with my population, that they don't realize that there is a program, Every Woman Counts. And so they are concerned, if I go and I find out something's wrong, and I'm concerned, where do I go if I don't have many? And that means even if you're insured, you can be underinsured. And if you're underinsured, then you're concerned about the copay. So Every Woman Counts is a resource. The Breast and Cervical Cancer Treatment Program is another resource if you were to need to have treatment. And talking to your doctor, I like to tell people you take someone with you. And also, since we are having limited time with our doctor, it really helps to create your questions. And in the beginning of the conversation with the doctor, to let that doctor know, I have some questions, I have concerns, and I would like to have time to discuss those. The other thing is to bring in, some hospitals have advocates and navigators, and bring in those navigators, ask to speak to a navigator, ask to have someone in there with you. The other thing in some of these locations, if you've been diagnosed with breast cancer, there are social workers who are assigned to work with specific doctors. Those social workers are there to be a liaison for you and to ensure that you are able to have a conversation and are able to meet with that doctor. I know that sometimes people don't feel comfortable saying something that this doctor isn't working out for me. But I think part of health equity is realizing that we do have choices. And in those times when you have those choices, to utilize them, to change doctors, to utilize the services that are available within the healthcare system.
Thank you, Dolores. That's great. And we've got a couple of questions that have come in from the audience, and I think I'd like to welcome everyone to come together as a panel and answer some of these questions. And it's important to have everyone's opinion and voice in here. So to the audience members, thanks so much for sending your questions in. There's been some really great ones. So the first one is, what are some ways you build trust with potential study participants, many of whom may have mistrust or have had negative experiences with health systems? What are some ways to build trust?
Kim, you want to start with that?
Yeah, sure. I've been thinking a lot about this because of my role as the Associate Director for Community Engagement in the Cancer Center. What my observation is, goes back to kind of what I said before about the relationships with various communities, and how we as academic institutions will pop in when we want something and then disappear sometimes when there's nothing for us to ask for. And what we don't create are sustainable long-term relationships, which are not really the kinds of relationships that are going to happen just based on individuals. So, you know, our academic lives tell us, you've got 5 years on this grant, this is what you're focused on, you're in the community, you're trying to engage with particular community in your clinic, and then after those 5 years, that engagement goes away. So what we're trying to do at UCSF, and through the Office of Community Engagement, is actually develop a relationship that lasts on the long term. And I like to talk about a ratio of give and take. When are we asking for, like, how often are we asking for something from people versus how often we're coming and bringing either resources or information, and offering, you know, ongoing partnership. And so what we're trying to do is make it such that our office is always offering something. We have, you know, quarterly webinars around different topics in cancer that are largely dictated to us by the community. And so when researchers kind of pop in and out, the community doesn't see the researchers as representing all of UCSF. And so when they're gone, UCSF is gone. So it really is about a long-term relationship. I mean, even if you're real nice in clinic, and I like to say this to individuals, it's like, just because you're nice is not going to deal with the historical harms of the relationship that the institution already has. What has to happen is that the institution has to work on that relationship with community. So one of the big things I would say, which is a system level thing, is we sit now on Mission Bay in, you know, about a mile north of Bayview Hunters Point, which, you know, people think of as Black, but it's actually quite a diverse neighborhood. So the question is, if we are to be embedded in the community like that, why is the community not embedded in us? because when people work at the hospital, have some kind of touch point with the hospital that is not clinical, then the give-take ratio there changes. So we're not always just asking for, you know, participate in a study or be in a trial or diversify my trial. So we're saying this is our place together that we're creating together. So when the ask comes, it doesn't feel as much of an ask because that ratio is closer to 1. There's as much give or a lot of give to kind of counterbalance the asking and taking that we do. So that's really a system level solution that I'm proposing. Less so than, you know, I think that the idea of cultural competence is just really, it's a little empty for me. And it's a little too simplistic because it relies on individuals. And the problems that we're dealing with right here are problems that are happening in population, which means they're happening on a systems level. So that's my approach on building trust.
I might say that, you know, so I've been, I think another way to build trust is your reputation and your work speaking for itself. So I've been working in the field of breast cancer and trying to build a more personalized approach for 30 years. And that I think that the issues, you know, the issues are those that you really are trying to express, that it goes beyond institutions. And we have tried that I think you need to show that your interest and desire to make a difference is not because you have to check a box on a grant, and it's not because you're trying to get something for 5 years, that there's a long, as Kim says, a long history of paying attention and being interested in and understanding that there's a disparity and a difference, and trying to find ways to make a difference that are, you know, that where your work can also help speak for itself. And we've tried to go beyond the institutions. And again, that's part of the reason why we're trying to build a trial that's really about women for women. And this trial, like the Women's Health Initiative or the Nurses Study or some of these other studies where people for many years have just gotten engaged and wanting to make a difference, what we want to do is appeal to the community and have it be something they care about, and make sure that it reflects them as well, because that's everyone's chance to make a difference in policy. You know, for our big I Spy trial, the trial where we, you know, are trying to look at high-risk breast cancer and try and understand better how to treat the more aggressive cancers, you know, we have a long track record of having really a very diverse population from I Spy 1 to I Spy 2. And part of that's, you know, making sure that our sites reflect diversity, that they reflect community, they reflect the academic community. We can always do better. And that's part of the reason we're working with Kim and Dolores and working with communities across the country where the institutions are in more diverse populations, and really trying to reach out. You know, I think that it has to be more than you're trying to check off a box. It has to be because you care about it and you think it's really important. You think it's important to the generation you're taking care of, and to their children and their children's children. And, you know, you have to walk the talk, not just talk about it. Dolores?
Yeah, I mean, when I think about building trust from a community standpoint, you know, agencies that are working within the community need to be able to be at the table, also to be able to bring in those researchers. And I want to say particularly ones who look like the population that they're working with, and being able to talk about your study and hear the questions and address the concerns, and also to look at the fact that there are advocates that tend to work on these grants and in these studies, and pulling from the community, you know, that you're working with, so that they have a buy-in and they understand. And when questions are posed, they can actually speak with some sense of commitment and belief and authority around why they believe that this particular study is beneficial to the community, to the individuals that will come after them, and to people's families, generation after generation. And that's one way that I feel sometimes we're lacking to have representation of those individuals from the community who also may not have ever been an advocate, but that's, I believe, the commitment to helping them, educate them, and giving them a chance to learn about what does this mean and how will it look when I can talk about it and I can share when talking with my family, when talking with my doctor, and overall talking with the community.
Great. Thank you, Dolores.
Can I add one thing to that, which is the opportunity to learn and participate is really important. The flip side of it that we never talk about is, what do we learn from listening? And how do we then tailor what we do, how we do it, when we do it, who speaks for it, from being in partnership with the community?
Right, 100%. And you know and I think that for a long time people had thought, well, why do you have advocates in the group? You know, aren't you advocating for your patients' best interest? Which I think sometimes physicians or researchers can confuse that. But in fact, there is a different perspective by someone who isn't medically trained, who's thinking about something different. And if you're not really speaking to the needs of the community, then you're missing the boat. And so you have to listen. We all have to listen. You know, I've learned the most from people who've complained to me about things not working or things not working. The people who complain usually wind up getting roped into joining my efforts and working on things. That includes Kim. Anyway, but but that's actually the best way we learn, is got to listen and pay attention and make it really be about the people who the work is supposed to help.
Great. So one last question, and then we'll do a little overview of the wisdom study and how we're working on trying to improve our equality. But the next one is about, what are some examples of engagement efforts or activities that have been most helpful in terms of raising awareness and facilitating recruitment? And I think the question is both in general and in research, but also specifically in the wisdom study.
You know, I think whenever we've had, you know, something that's broadly distributed, like on radio, I think you get a really diverse audience listening. I think, you know, groups where people can come, where you can go into a community and people can come and ask questions and hear about it. And when people have the time to learn about it, think about it, and have the chance to participate, and then they can tell their friends, that really has helped us. But I think that's particularly one of the reasons why, if we don't really do a good job of getting kind of at the earlier part of the trial, you know, a broad inclusion of all women, including Black women, Latino women, you know, all Asian women. If we don't do that, when the friends and family get invited, you know, it's not going to reflect the population. And that's, I think, a real problem.
Thank you. Dolores, any thoughts on other ways in which community engagement or recruitment within the community has been successful?
Well, at the Women's Cancer Resource Center, what I've used is speaking engagements, because often I'm asked to go out and I speak to various groups, whether it's the seniors, it's at schools, going out to faith-based sites, community sites. And of course, we know that a person can't hear the message once. So it is continuing to bring up that message about the wisdom study, to talk about the importance of understanding and doing what's right on an individual level for each person around the breast health. The other thing is that we have used our outreach events at various locations to talk about the wisdom study. Our volunteers have learned about the wisdom study. So this is something that we continue to bring up every single time we get a chance to talk about it in our support groups, at our sister-to-sister events, at within our Latinx services, telling people over and over and then reiterating why it's important is how we've worked to champion about people participating in the wisdom study.
Well, Kim, any other thoughts?
Well, I think in general agree with the need to have input and endorsement and buy-in come from community. Because I think that even though we may create a roundtable and check every box that we have somebody who looks like each of these categories, it doesn't necessarily mean that the folks who are around the table are sort of the local influencers or the people who have their finger on the pulse of the situation. So I think the closer you can get to what's happening on the ground in people's real lives and having those folks who have influence, larger spheres of influence engaged, I think that those strategies, in my experience, have been the most successful.
Thank you, Kim. Okay, we have just a little over 5 minutes left. So we wanted to give you guys just another brief overview of the wisdom study and some of the ways in which people can get involved. So Laura, we'll have you, I think a couple of these slides we can probably skim over for time's sake, and you've touched upon some of these already. But I think some of the questions were around timeframes and just again, what it takes to participate. Oh, Laura, you're on mute.
Sorry, I'm Rebecca. Yeah. So the good news about this study is you don't have to be part of any institution. You can do it on your computer, on a phone. You can go to a kiosk, and all you have to do is go to wisdomstudy.org and have a way to get information through that same link, set up an account for yourself. And what we're really interested in is a broad section of women starting at age 40, where we make the normal ways to do things, and we're going to compare what is considered to be the gold standard, which is one size fits all, women 40 and above, and compare it to an approach where we are personalizing when to start, when to stop, how often to screen. So using information about your genetics, really learning about the genes you inherit, from the rare mutations that really increase risk to the small variations in genes that can all, when put together, can make an impact either to lower your risk or raise your risk. But the idea is if your risk isn't so high, you don't need to screen as often, and then you're not going to likely get some of the false negatives and the callbacks that really are very stressful to women. Whereas, if you really have higher risk, then we want to screen you more frequently. And, this is a good start. We know in the future we'll be able to keep making it better, but the point is to start now. Is it just as safe to take a more personalized approach where we do less for some and more for others? And that's the point. And again, we really want women to join and say, look, this is important to me. It's important to my family, to my daughters, my mother, my friends, next generation. And that means the obligation is simply, to follow you follow whichever recommendation you've been given. And again, we're trying to be very patient-centered. Some people don't want to be assigned by chance to either the personalized arm or the annual arm. If you feel really strongly and that you're not going to take a recommendation other than screening every year starting at 40, then choose the annual arm. But if you're interested and you say, look, I don't want that necessarily, I only want the personalized, you can do that. The best way for us to learn is if people are willing to be assigned by chance. And again, it's just 5 years that you participate. But so all those options are available. And if you're confused, we're going to actually set up office hours where every couple of weeks you can ask any question you want. And if you're concerned, if you get assigned something and your physician doesn't agree with it, that we have a way that we can communicate with them. You can just enroll again by going to wisdomstudy.org. Everything is done virtually. The one thing we have to get is just the density on a mammogram. If you've had a mammogram, if you're going to, for the genetic testing, it comes in a little kit to your house. You just spit in a little cup, put it back in the mailbox, and that's the end of it. But, again, the study will succeed or fail by people being part of it. This is a community. We're asking everyone to come together to say, no one has really done the work that it takes to figure out what's the best way forward. And I'm really frustrated about that. I think women deserve better. All women, though, not just white women, or, you know, we want Asian women, Latina women, Black women, brown women, everybody. We want everyone to participate and say, hey, we're taking this into our own hands. We're going to participate. We're going to make this study successful. We're going to generate the information that helps us understand what's the best way to screen. And we're going to share the data with you. So this is really why it's important. And some people ask, wow, in the time of COVID, how can you be talking about breast cancer screening? Well, let me just give you a couple of facts, so that if you, again, if you wear a mask in public, you dramatically reduce your chance of getting COVID, and you reduce the chance of spreading it, especially when you talk. 100-fold difference if you wear a mask when you talk. So what's the chance that you would get COVID versus find a cancer that might actually be treatable and make a difference in your outcome? It's about 50 to 70 times higher for a 60-year-old woman, a little less when you're maybe 20 or 30 times if you're 40, but it's like, factors, more than a factor of 10-fold, that the benefit is worth the risk. And if you actually have a cancer that you choose not to treat, the difference is like 10,000 times. Your chance of dying of COVID, the benefit you would get is 10,000 times your risk of dying of COVID. So, we are learning in this very challenging time that you can still go about doing the things that are important for you as long as you take some public health precautions. So we feel like these questions are still important, that, cancer, breast cancer is still a huge issue for women, and it's a huge issue for women of color. And so we want people to take it seriously and help us find better answers. And we want those answers to reflect all of you, right? So that we don't have to continue to make one-size-fits-all recommendations to people. So we hope you'll join us, and tell everyone you know to join us. It's the only way that all of you are the ones, it's in your hands to make a difference and to help us generate the kind of data that will help you and your family and generations to come.
So thank you, Laura. One last poll asking people if they would be willing to participate in something like Wisdom. So bring up that last poll question, and then we have some resources for you on the last slide.
I'm skipping the Jeopardy thing.
Great, awesome. Okay, so it looks like close to 90% of people would be willing to participate, which is awesome. So on the next slide, there are some different ways to be engaged. So obviously we'd love to have you join the Wisdom study, but not everyone is perhaps eligible. There are lots of ways to get involved. We've noted a few of them here, helping us with community promotion. If you're part of a community group or you know of a community organization that you think would be interested in partnering with us, sharing the Wisdom study across your networks, whether those are personal or professional or community networks, giving us your feedback. If you've joined the study, let us know how your experience went. We want to know how to improve the experience for everyone. And also, you could be a Wisdom ambassador. We have some more information about that we can send, but helping promote Wisdom and suggesting new outreach strategies as well. So there's lots of different ways to get involved. On the next slide, we just want to thank anyone who is already a Wisdom participant. Thank you so much for being part of this important research and being part of this important study. A reminder to log back in and complete your surveys. We need you to stay engaged and to keep us updated. And please do share the study with your family and friends. If you have not yet joined, you can go to the website to sign up. And again, if you're not eligible, please do help us spread the word. If you have any questions, please do let us know. We are up on time, and there are some questions that didn't get answered. We get access to those after this webinar, so we'd be happy to follow up with you after the webinar with those questions if we didn't get them answered.
And I just want to add my thanks to everyone who joined. And again, if you are concerned about something, or you have a problem when you're using the website or getting on, or you have suggestions, really, we listen to every suggestion, criticism, everything. That's the only way we get better, is that we do listen and we really do care. And I want to then a special shout out and thanks to my friends and colleagues, Kim Rhodes and Dolores Moorhead. Really thank you for being involved and taking the time and helping us to make the study better. We're just so grateful for your participation. And again, to all of you for listening, thank you so much for taking the time to join us. We'll be doing this every month. And again, we're going to set up our office hours every couple weeks for questions.
Great. Thank you, everyone. Have a great rest of your day. Bye.